Hello, everyone. Thank you, Dr. Bass and Professor Bess, for the invitation. So it's a nice transition, I think, because we are talking about a French initiative on French harmonization for post-op radiotherapy technique. I will not talk about again the ESMO guidelines, but there's a gray zone that lays between stage 2A, 2B, and 3 for thymoma. So the radiorhythmic trial was started in this context in the rhythmic network, and patient with thymoma histology R0 with the stage 2B and 3, as Professor Girard told you before, were included. Before randomization, pathology review was compulsory, and patients are randomized between post-op radiotherapy to non-post-op radiotherapy, with as primary endpoint relapse-free survival and secondary endpoint local regional survival, distant metastasis-free survival, overall survival, and toxicity. First patient included in the end of 2021. So before entering into the trial, as it's quite classical in radiotherapy studies nowadays, patients centers needed to complete a Damiran. So 2 clinical cases, one with neoadjuvant chemotherapy and one without. 14 centers completed the Damiran and our country enrolling. And for the trials, we based the part recommendation on the ITMID recommendations of 2011 of Gomez et al. That we all used up to now. And in reviewing the cases, the contours, we actually observed quite a large variability between among the participants. And here, maybe you can spot it. Mostly in the CTV definition, but not only in the CTV definition. So here the CTV encompasses the sternum and the vascular structures, and the craniocaudal limits are not very clear. So we decided to, with the scope of being a bit harmonize the radiation practices within the clinical trial, but actually not only, and to refine the key recommendations, we decided to build this consensus based on a Delphi methodology, especially for those patients. So patients with thymoma in stage 2B3 completely resected, but of course, by extrapolation, we can also extend it to to other thymoma patients. So a scientific committee of 9 experts was selected. So of course, it was multidisciplinary. There were 6 radiation oncologists, so a bit biased towards, of course, the radiation oncologists, 2 clinical medical oncologists, and 1 thoracic surgeon, and we performed, because I was part of the scientific committee, a literature revision, and we identified 4 main topics around which we defined 115 questions. And we selected the expert panel, of course, within the participants of the rhythmic trial, but not only. We selected patients among the active members of the rhythmic network, and they were 24 experts, multidisciplinary as well. So radiation oncologists mainly, but almost a half, I think, but also medical oncologists, pneumologists, surgeons, pathologists, and of university hospital, but not only, also some private practice hospital. So we elaborated this questionnaire, and we diffused with in this first round of submission the questionnaire to the expert panel. So the adherence was quite good. 83% of the experts participated and answered to the question. This was 2 years ago, so in March 2023. The scientific committee analyzed the results, and consensus was reached on 28 questions. So we discussed about those questions and about the key points and about the state of the art and the available literature in a 2 hours workshop. And after the workshop, a second round of submission was diffused to the experts selected. And adherence was quite good. 71 of them resisted, so they replied 2 months after the first wave. And we analyzed the results as a scientific committee, and we elaborated a consensus on 33 questions. So to note that we switched from a simple agreement to a consensus in 6% of the questions. And then we presented the results and we elaborated the consensus. So we identified 4 main topics. The first one, the imaging techniques. The second one, the definition of target volumes and CTV, PTV margin. The third one, those constraints to organs at risk, radiotherapy technique and fractionation. And fourth one, follow-up and reporting in medical records. And for the first topic, imaging techniques, we identified consensus was reached for 94%. Every patient needed to have a contrast enhanced CT scan. So this might seem quite basic, but in the literature, we didn't find any other argument for proposing another supplementary pre-surgical imaging modality like MRI or PET scan. As for the radiotherapy CT scan, we all agree that, of course, as recommended by the Radiotherapy Society, motion management is needed. The type of motion management, we fear that it has been a bit biased by the availability of the motion management available in the centers, because the vast majority of us was for the CT scan and discouraging free breathing whenever possible. And of course, deep inspiration breath techniques, they didn't reach a consensus, but we suspect it's for the less availability of those techniques. And of course, daily EGRT, those are quite, I would say, basic staples of a radiotherapy treatment. And then when we go toward the definitions of the target volumes and the organs at risk and the margins, it gets a bit more interesting, in my opinion, because we discussed about the fusion. So we recommend, the vast majority of us recommends a fusion, a rigid fusion between pre-surgical imaging and dosimetric CT. So as we can see, we suggested a fusion based on cardiovascular structures, but it can be sometimes challenging. So mostly with a rigid fusion, sometimes it can be difficult, but we agree that it was for us the best available option. And maybe you can spot it here. We suggested to, and we reached a consensus on the definition of an RGTV, so a resected GTV, a GTV based on, well, the dosimetric post-surgical anatomy, but taking into account the pre-surgical anatomy and the post-surgical rearrangement. So as for the limits of the CTV, what are the limits? Well, we agreed on the fact that only the anterior limit was clearly, we can identify only the anterior limit. So the sternum is the anterior limit of the CTV. So no need of additional margin on the bone structures because there's no infiltration, almost never. But as for the superior, inferior, and the lateral limits, we reached an agreement, but not a consensus, meaning that there is not a clear definition on the upper and lower limit. And we simply stated that it required additional standard limits from the RGTV for both cases. And as for the anatomic barriers, where bones were considered as such by the vast majority of us. So as you can see here, from this CTV, the bones are excluded. But do we have to exclude also vascular and vessels, blood vessels? Well, we reached an agreement, but not a consensus. So not necessarily was our reply. And long discussions on the surgical clips, because we reached an agreement, 53%, but not a consensus on the fact that they should not be considered as an indicator of tumoral location. And we discussed, well, there were lengthy discussions about that. So as for those constraints to the organs at risk and the dose and the fractionations, we all agreed on the fact that there is, well, a very emerging awareness on the importance of heart and cardiac substructures not only in, well, in thoracic radiotherapy, not only in breast cancer, but also in lung cancer. So we all agreed on the fact that we should take it into account somehow. So we should contour cardiac substructures. Which ones? Well, here I will report you two papers, two atlases that are quite useful and handy in radiation oncologist, of Duan and Milo, published a few years ago. So we recommended in our consensus to delineate at least the coronary artery and the left arterial descending, and to spare one of them if possible. And as for the dose constraints, we agreed, but no consensus was reached again on the fact that we should use lower, stricter dose constraints than, for example, in lung cancer. But again, we could not really quantify it. And for the radiation technique, EMRT and VMAT, as it's well established in lung cancer and lymphoma, for example, should be used with a 50 grays or equivalent dose in standard fractionation. So last item, follow-up and medical records. Toxicity, well, cardiac follow-up should be done in, according to our consensus, in all patients, at least at 5, at 10 years. And quite interestingly, a very large consensus was reached on the fact of establishing homogeneous histologic pathology records and surgical records, which when it's possible to have a sort of schema, surgical schema of the surgery that has been performed. So in conclusion, this is the first Delphi consensus to refine a bit port recommendations that were based on an ITMIC consensus of 2011, and similarly to ours. A Delphi on thymic carcinoma was published in 2023. And in the end, our recommendations, of course, are a consensus, just a consensus, and based on evidence with strength of B and mostly C. And they have been, of course, implemented in the radiorhythmic trial to have to harmonize the technicalities of the radiotherapy. And of course, thank you.